Insurance at the local level, hosted by the California Healthcare Foundation. I am Chris Perrone, Director of Improving Access at the Foundation, and I will be today's moderator. Today's webinar features an effort by San Francisco leaders to improve the affordability of health insurance. And the purpose of this webinar is to describe the underlying goals of San Francisco's new program and share the approach and findings of the analyses that supported city leaders' evaluation of program design options and ultimately their program design decisions. This webinar, and more importantly San Francisco's effort, occur against a backdrop in California and the nation where we've seen historic gains in health coverage over the past 2 years as a result of the Affordable Care Act and in California and many other states, the expansion of Medicaid. Despite these gains, cost remains a barrier to coverage and care for many individuals and families. According to a recent national survey conducted in 2014 by the Commonwealth Fund, nearly 1/3 of working-age adults reported delaying care in the last 12 months due to cost. And in California, the latest tracking poll from the Kaiser Family Foundation shows that 44% of the remaining uninsured say it's because health insurance is too expensive and they can't afford it. At the California Healthcare Foundation, we have made it a priority of ours to improve access to care for low-income populations. And as part of this effort, we aim to make health insurance coverage easier for consumers to get, understand, and use, and addressing affordability is a key lever. We were delighted when local officials in San Francisco reached out to us to support designing their program to address the affordability of coverage at the local level. And we're hosting this webinar today to share the work we supported with a national audience and to invite local officials and stakeholders in other California counties to reach out to us if they are interested in bringing this type of technical assistance we supported in San Francisco to their communities. We'll start today's webinar by hearing from Anika Chaudhry and Colleen Chawla from the San Francisco Department of Public Health, who will provide some program context. We'll then hear from Laura Lucia at the UC Berkeley Center for Labor Research and Education about the affordability analysis they conducted for this effort. And then we'll hear from Don and Donna from the Health Management Associates, who will describe the program design options they examined and their methods. And then we'll hear again from Anika and Colleen about the project outcomes before we wrap up the formal presentation and take your questions and respond to them. Following the presentations, we hope to have at least 30 minutes for Q&A. Before I turn things over to Anika and Colleen, some housekeeping about today's webinar. First is that the webinar will be recorded and posted to our website within a week, probably within 24 hours, along with the presentation slides. All participants will be in listen-only mode. Please do not place this call on hold. If you need to exit the call, please do so, and you can always call back in. If you have a question, please type it in the chat box, and we'll try to answer as many questions during the webinar as time allows. With that in mind, Anika and Colleen, the floor is yours.
Thank you very much, Chris. This is Colleen Chawla from the San Francisco Department of Public Health. I'm actually going to turn it over to Anika Chaudhry since she did the lion's share of the work on this project and is really the most knowledgeable. But before I did that, I wanted to make sure that I thanked the California Healthcare Foundation for providing a generous grant to allow us to look into this issue and to devise a solution for San Francisco, and also Health Management Associates and the UC Berkeley Labor Center for their expertise to help us design this program. So with that, I will turn it over to Anika.
Thank you, Colleen. So before we get into the nuts and bolts of the presentation, I thought it would be helpful to go over some terms that you'll hear a lot of the presenters talk about. The first step is the Healthcare Security Ordinance, or the HCSO. This is a San Francisco ordinance that was passed in 2007 and essentially requires most employers in the city to make healthcare contributions, toward their employees' healthcare costs. And I'll provide a little bit more detail about this on the next slide. Secondly is Healthy San Francisco. This is San Francisco's healthcare access program for the uninsured, which was also created by the HCSO in 2007. Next up is the city option, which is one of the ways that employers comply with the HCSO, and they do so by making payments to the city. And the city option is administered by the San Francisco Department of Public Health. And depending on the employee eligibility, the city enrolls the employee either in Healthy San Francisco or City Option MRA. The City Option MRA is medical reimbursement account that's available to employees for a variety of health expenses, including health insurance premiums and out-of-pocket costs. And finally, the public benefit program is what we named this project during its development phase. Next slide, please. So this is a graphic depiction of the San Francisco Healthcare Security Ordinance. There are two components. The Healthy San Francisco, which, as I mentioned, is our healthcare access program for the uninsured at low and moderate incomes. And this is available to all uninsured San Francisco residents regardless of immigration status, but it is not insurance and provides care through a coordinated network of providers only within the city. At the top, we have the employer spending requirement, which obligates any employers with more than 20 employees and nonprofit employers with more than 50 employees to make quarterly contributions on behalf of any employees working more than 8 hours per week. The rate that the employers make the contributions at is an hourly rate that's set by the size, that varies by the size of the employer. So employers can choose to comply with the law in a number of ways, and many of them use a combination of approaches. But by far, the most common approach is to offer comprehensive health insurance. This is used by more than 80% of the employers, and followed by a third-party health reimbursement accounts and or the city option. Next slide, please. The city option ties the employer spending requirement and Healthy San Francisco together. And as I mentioned earlier, this is administered by the San Francisco Department of Public Health through a third-party administrator. And once the employee receives a contribution from their employer, if they're eligible for Healthy San Francisco, meaning that they're an uninsured San Francisco resident meeting program requirements, they can enroll in Healthy San Francisco. If they are not a San Francisco resident or they already have insurance, they are set up with a city MRA. Prior to health reform, the two, Healthy San Francisco or city MRA, were mutually exclusive, but we made some programmatic changes to allow people to transfer their Healthy San Francisco contributions over to the MRA to help them buy insurance. Next slide, please. So against this background, I'll talk a little bit about why we undertook the Affordability Project. So San Francisco saw huge success in the implementation of the Affordable Care Act. We had over 97,000 people enroll in ACA coverage since 2014, 41,000 of them through Covered California and another 52,000 through Medi-Cal. Consequently, we've seen our uninsured rate drop by more than 54%. And this is largely due to the success of Healthy San Francisco. So in 2013, prior to the launch of the ACA, we had about 80% of the city's uninsured enrolled in Healthy San Francisco, and we were able to outreach and help them transition to insurance options under the ACA. And so since 2014, January 2014, we've seen enrollment drop from over 52,000 to just under 15,000 in July of 2015. However, despite this success, we note that affordability and coverage challenges do remain because not everyone is eligible for coverage under the ACA. So, for example, the undocumented. Many others are eligible for the various affordability exemptions that are available, and others still just have a difficult time affording the coverage that is available to them. So parallel to the launch of the ACA, there's been citywide interest in addressing the issue of affordability of health insurance. In 2013, the mayor reconvened the Universal Healthcare Council, which was the initial stakeholder process that helped create the Healthcare Security Ordinance, to see how our local ordinance meshes with the ACA. And the Universal Healthcare Council found that the HCSO can exist alongside the ACA, but there are affordability challenges remaining for certain populations, notably low-income employees as well as those working for small employers and those working part-time. So in 2014, the Healthcare Security Ordinance was amended to make various alignments with the ACA, but one of the requirements was for the health department to address the issue of affordability for health insurance in San Francisco by leveraging the Healthcare Security Ordinance. Next slide, please. So from our background research, we had a few project goals in mind. We wanted to be able to define affordability specifically in the San Francisco context. So what does it mean for a San Franciscan to not be able to afford health insurance? And to mitigate that concern, we wanted to be able to provide a meaningful benefit that would address the challenge. And we were open to doing this through premium assistance or cost-sharing assistance. We wanted to be able to maximize any available federal subsidies while minimizing administrative complexity for the program administrator as well as for the ultimate beneficiaries of the program. And lastly, but not leastly, we wanted to be able to leverage employer contributions that are made to the HCSO city option. Next slide, please. And so from a very generous grant from the California Healthcare Foundation, we were able to engage UC Berkeley Labor Center and Health Management Associates to help us with the research and analysis to help us develop a proposal that would address affordability. So UC Berkeley helped us with the numbers. They came up with affordability measures that we could apply to define affordability in that San Francisco context that we were looking for. And they were also able to leverage and customize their CalSIM model to help make some projections for program uptake, costs, as well as revenues. Health Management Associates, we asked them to use their expertise in the logistics of operationalizing a program. So how exactly would premium assistance or cost-sharing assistance work? And we asked them to conduct financial, regulatory, and operational feasibility analyses, and then to ultimately make some administrative structure and benefit design recommendations. Parallel to this process, the health department undertook, we conducted some employer and employee focus groups for covered employers and employees who participate in the Healthcare Security Ordinance. And from these focus groups, we found that employees, whether they were insured or uninsured, cited cost as their chief concern in terms of health care. And employers said that they wanted to be able to offer health insurance, particularly to their part-time or low-wage employees, but it's not always possible either because of cost or because many insurers won't insure, don't allow the enrollment of part-time employees in their employer-sponsored plans. And so we asked the consultants to use this employer and employee feedback and incorporate it into their research as well as into their recommendations. And so now I'll hand it over to Laurel to talk about the affordability analysis.
Hi, this is Laurel Lucia from the UC Berkeley Labor Center. Today my presentation is going to focus on the affordability analysis we did. We took 4 different approaches in looking at affordability. 3 were San Francisco specific and examined both premium costs and out-of-pocket costs. And we also took one approach that was statewide and examined the size of the deductible and covered California Silver plans. Another big part of our work on this study was estimating the potential population and program revenues and costs, as Anika mentioned. We did that using our California Simulation of Insurance Markets model, or CalSIM, which we made adjustments to based on administrative data from the city option. But today I'm going to focus just on our affordability analysis. And if you'd like to see details of the other analysis we did, it's in the final report, which is shown in the link below. Next slide. So I wanted to start by acknowledging the major advancements in affordability we've made under the Affordable Care Act. Many Californians have gained coverage as a result of the premium subsidies under the Affordable Care Act, and surveys have shown that those who have gained coverage have had an easier time paying bills, medical bills, because of it. But affordability is still a barrier to some Californians. Kaiser Family Foundation did a survey where they followed up with Californians who were uninsured prior to the Affordable Care Act to ask about their coverage status in the spring of 2015. And they found that the most common reason for remaining uninsured was not being able to afford insurance. 44% gave that response, which was the most common response. They also found that among the uninsured, affording health care is their top financial concern. uninsured Californians ranked affording health care higher than affording housing, gas, utilities, and food. Next slide. But even among those who have insurance, affordability can still be a barrier to timely and appropriate use of care. Research by the Commonwealth Fund has found that privately insured adults in the U.S. That have deductibles that exceed 5% of their income are more likely to delay or avoid needed care. So for example, they're more likely to have a medical problem but not go to the doctor, to skip a preventative care test, or to skip other treatment or follow-up that's recommended by their doctor. And it's not just deductibles that can be a barrier. The Commonwealth Fund has also found that low-income individuals who are unable to afford copays and coinsurance may also delay or avoid needed care. Next slide. So affordability remains a concern for some individuals both in California and nationally, but it's especially a concern in high-cost areas like San Francisco. So we used the California Budget Project's Making Ends Meet budget to do some analysis, and that budget reflects the minimum cost to cover housing and utilities, child care, transportation, food, and miscellaneous expenses. They also include health care and taxes in their budget, but we've taken those out for this slide because we examine those later in respect to specific income levels. Actually, that last slide, I just wanted to highlight that what we found from that budget is that in San Francisco, the monthly expenses under this budget for a family of 4 are $1,000 more than the California average. And I also just wanted to note that this is truly a making ends meet budget. It doesn't take into account expenses that are common to many Californians, like having a cell phone, going on vacation, or contributing to savings. Next slide. So using this budget, our first way of analyzing affordability in San Francisco is shown here. I will walk through the graph in a second, but I just wanted to highlight that all of our analyses focused on the cost of health care for the individual worker, even if they are part of a family, because the program that San Francisco was considering was focused on the individual worker's costs. So just to walk through one example, we'll walk through the single 40-year-old in San Francisco. What this graph is showing is that an individual below 255% of the federal poverty level, which is about $30,000, that's the gray bar at the top, would have no room in their budget for any health care expenses, assuming they were living with a making ends meet budget. And this is purely a reflection of the cost of living in San Francisco. Those who have slightly higher income, the red bar between 255% and 285% of the federal poverty level, may be able to pay some of the premiums for a covered California plan after the federal subsidies, but would not have any funds left over for out-of-pocket costs. Then the light green bar shows between 285% and 305% of the federal poverty level, single individuals may be able to pay their premium after the federal subsidies, but they wouldn't necessarily be able to pay all of their out-of-pocket costs. And finally, for a single individual, it's at 305% of the federal poverty level, or about $36,000, where an individual would likely be able to afford premiums and out-of-pocket costs. And as you can see from the chart, the income levels at which families can afford premiums and out-of-pocket costs are somewhat higher. Next slide.
Hey, Laurel, this is Chris. Somewhere along your presentation on this slide, the quality of the line seems to have deteriorated. It sounds like you're talking underwater. I don't know if there's anything changed on your end, but there's anything you can do
Should I
to improve
redo
it,
this?
please do.
Start over with this one?
No,
okay.
But I don't know, did you?
I'm on the same line on the handset, so I'm not sure what might have happened there.
Yeah, okay. Well, we will...
let me know if it happens again. So a second approach we use to look at affordability also focused on the local cost of living in San Francisco. The Public Policy Institute of California and researchers at Stanford developed a California-specific poverty level, and then they further adjusted it for housing costs in each county. So what this table shows is the right three columns are the subsidies or the benefits that are currently provided under the Affordable Care Act by federal poverty level. And the first column on the left-hand side shows what the equivalent federal poverty level would be for a San Francisco renter if the federal poverty levels were adjusted for local cost of living. So the significance of this is that you can see in the last line, if federal poverty levels were adjusted based on cost of living, premium subsidies in San Francisco would go up to about 635% of the federal poverty level, which is $74,000 for a single individual. And cost-sharing subsidies, which are shown through the enhanced silver plans on the right-hand column, would extend up to almost 400% of the federal poverty level if the federal poverty levels were locally adjusted. Next slide. So the third approach we took is looking at what share of income would a single 40-year-old adult spend on premium and out-of-pocket costs, given different levels of medical use. Now, there's no good standard for what percentage of income is affordable to spend on premiums and out-of-pocket costs, but this approach helps to identify the households that are most at risk of affordability concerns. And so, as you can see from the chart, the green line shows individuals with very high medical use, and at certain income levels, those individuals could spend as much as 30% of their income on premiums and out-of-pocket costs. Next slide. The fourth and final approach we took to examining affordability was focused on out-of-pocket costs in particular. And using we used the Commonwealth Fund definition of underinsurance, which has two components. They say that individuals are underinsured if their out-of-pocket spending, excluding premium costs, equal at least 5% of their household income if they're low income, or at least 10% of their income if their income is over 200% of the federal poverty level. A second way of being considered underinsured is if you have a deductible that is at least 5% of your household income. And separate research from the Commonwealth Fund has found that individuals who are considered underinsured report substantially higher rates of medical bill problems than those who are insured. They're more likely to report financial problems like a lower credit rating, using up all their savings, having credit card debt, declaring bankruptcy, and they're more likely to delay or skip care. Next slide. So for the purpose of this analysis, we focused on the deductible aspect of the underinsurance definition because we don't have data on actual out-of-pocket expenditures in covered California by income level yet. So looking at the covered California silver plans for each income level and the associated deductibles, we found that individuals between about 200% of the federal poverty level and 400% of the federal poverty level would meet the definition of underinsurance. And I just wanted to note that these are the deductible amounts for 2015 Covered California plans. They'll be slightly different next year. Next slide. So just to sum up the kind of 4 different approaches and what we found, assuming a making ends meet household budget, we found that additional financial assistance is especially needed below about 415% of the federal poverty level, but the exact threshold depends on the family structure. We also found that if ACA premium subsidies were tied to the local cost of living, that subsidies would be offered to families with income as high as 635% of the federal poverty level in San Francisco. Individuals with higher medical use levels are especially at risk for high health spending as a share of their income. And then finally, we found that the Covered California Silver Plan deductibles for single individuals with income of approximately 200 to 400% of the federal poverty level meet the Commonwealth Fund definition of underinsurance. So now I will pass it over to Don and Donna at Health Management Associates.
Thank you, Laurel. Good afternoon. My name is Don Novo, and I'm a principal with Health Management Associates. My colleague, Donna Laverdia, and I are going to give you some background on our analysis and discuss the program design options that were developed for this project. Next slide, please. Through our discussion, we will talk about the work undertaken by the HMA team involved in the review of programs, both San Francisco's Healthcare Security Ordinance, the city option program that was created under that ordinance, and a number of other programs nationally. Our team has interviewed operations staff at Covered California, California's state-based health insurance marketplace, along with staff from the qualified health plans participating in Covered California and serving in the San Francisco County Covered California defined region. We reviewed findings from a series of focus groups conducted by the San Francisco Department of Public Health. The first focus group consisting of employers that contributed under the Healthcare Security Ordinance, and the second focus group that was comprised of employees who received benefits through an HCSO option. We'll walk through our evaluation options against defined program criteria, and we will discuss the considerations that we reviewed as to the existing program structures and funding sources to fund program operations. Next slide, please. We wanted to talk with you a little about the existing health benefit programs that we reviewed. Our analysis looked at existing health benefit programs that are currently in operations in a number of states. We looked at both public programs such as Medicaid, health insurance premium payment programs, and other programs such as union programs that assisted employees with supporting the cost of their health insurance. Our analysis also looked at the mechanics that both HIP programs and private programs utilize, connecting participant payments and program payments together. Our review looked at the mechanics used for making payments, whether organizations made direct payments, if they utilized a voucher, or if they provided other subsidy options. On the screen, you can see there are a couple different of the premium assistance programs that we reviewed. We looked at a variety of Medicaid health insurance premium payment programs. They're known as HIP programs, and these are programs that assist their enrollees with the purchase of employer-sponsored insurance when it's cost-effective. We also looked at a unique program, which was the Oregon Home Care Workers Program, and this program provided premium and cost-sharing subsidies to Oregon SEIU members that worked in the home care and personal support area. Next slide, please. As part of our analysis, we conducted interviews. Our team interviewed Covered California staff to discuss the options for automating a public benefit program within the existing Covered California structure. Through assistance with Covered California, we were able to identify both short and longer-term needs. We also had discussions with 4 out of the 5 qualified health plans that participate within the San Francisco Covered California region. Through these discussions, we were able to evaluate strengths and weaknesses of various program options and to determine which options were most feasible. allowing San Francisco Department of Public Health to meet their goal of 2017 open enrollment implementation. My colleague Donna Laverdia is going to discuss the benefit design options. Next slide, please, and hand it over to Donna.
Okay, thanks, Don. For the public benefit program, we looked at 3 ways of structuring the benefits that would be provided to eligible participants. We looked at providing both premium assistance and cost-sharing assistance to eligible participants, given what we learned from UC Berkeley's affordability analysis. And I should note that each of these benefit approaches would base the premium assistance amount on the cost of the second lowest cost silver plan that is available in the San Francisco service area. So the 3 options that we looked at, the first option was tiered premium assistance. So for people with incomes up to 400% of the federal poverty level, they would receive 100% of their premiums in premium assistance payments. And for people with income between 400 and 500% of FPL, they would receive 40% of their premium. The second option was flat premium assistance of 80% of premium for individuals with incomes up to 635% of FPL. And the third option was flat premium assistance of 60% of premium, plus cost-sharing assistance to reduce the plan deductible to 5% of income for individuals with incomes up to 500% of FPL. Next slide, please. So we looked at 3 evaluation criteria to evaluate the different benefit design options. The first was maximizing the number of participants who would be covered given the funding that was available. The second was maximizing the affordability of healthcare coverage based on the affordability analysis. And we looked at 3 measures that Laurel discussed earlier in the presentation: total health spending as a percent of income, premiums and out-of-pocket costs compared to a household budget, and underinsurance, so which is defined as when a deductible exceeds 5% of household income or out-of-pocket expenses exceed 5% of income for people under 200% of poverty and 10% of income for people above 200% of poverty. And the third criteria was minimize the complexity of the program, both for the public's understanding of the program and for the administration of the program. Next slide, please. And this slide just shows estimates in terms of the number of people who would take up or participate in the program based on the 3 benefit design options, the total subsidy amount that would be provided under the 3 options, and looking at the range of the remaining cost of it as a percent of income for healthcare costs, and looking at utilization in a range in terms of low to high. Okay. In addition to the benefit design for the public benefit program, we also examined the administrative structure that the city could use to carry out the program. At a basic level, we needed to devise a way for the assistance to be provided to each program participant, either directly or through the health plan that they select. We examined separate options for the provision of premium assistance versus cost-sharing assistance. So for premium assistance, we looked at 4 administrative structure options. The first would be making payments directly to qualified health plans on behalf of eligible participants that would reduce their premium amount. The second option was contracting with a single qualified health plan issuer that's offered through Covered California and making payments to that single plan to reduce the program participants' premium amount. The third option was utilizing the city's existing medical reimbursement account structure to allow participants to receive reimbursement for premium payments that they make. And the fourth was providing a debit card to participants to make payments directly to their health plan in combination with a medical reimbursement account for lower assistance amounts. And this is because we heard from qualified health plans that they would not be able to receive more than one form of payment for a single premium bill, so a debit card would only be feasible if the participant was receiving 100% premium assistance. Next slide, please. So for cost-sharing assistance administrative structures, we looked at 3 options. The first was making payments to health plans to offset the cost sharing required for services provided to eligible participants. The second was providing participants with a debit card with a set credit amount so that they could make payments for their out-of-pocket expenses directly when they access services. And the third was using the city's existing medical reimbursement account so that the person could submit receipts and receive reimbursement for eligible cost-sharing expenses. And to evaluate the administrative structure options, we used 5 criteria. The first is maximizing program participant take-up and ease of use. So we wanted to maximize the number of people who would participate and also make it easy for them to do so. Minimizing any legal barriers that exist. Minimizing the time for implementation. Maximizing operational feasibility for the qualified health plans, and this is where our interviews with the qualified health plans that participate in Cover It California came into play because there were certain operational structures that would or would not work for them. And minimizing the administrative cost burden for the city. So in the end, we recommended to the city that for premium assistance, they use either a combination of a debit card and the MRA account or just the MRA alone. And for cost-sharing assistance, again, we recommended that they utilize either a debit card to allow people to make payments directly for out-of-pocket expenses or the MRA for people to be able to submit for reimbursement for those expenses. And in terms of the implementation of the program, we recommended that the city implement the program within their existing TPA structure that they have in place for Healthy San Francisco and the city option to maximize operational efficiency and their ability to implement the program in the time that they had available. And with that, I'm going to turn it back over to Don to wrap up our section of the presentation.
Thanks, Donna. So the last thing that we want to discuss on the HMA side really is the application of public benefit program options to other local entities. So really we could be discussing, could be considering another county or state or some other structure that would be looking to implement a public benefit program. So things that other entities will need to consider when developing their own unique public benefit program. And we've listed some of those items up on this slide, really to evaluate the cost of living and the affordability of health insurance in the proposed program area. And Laurel really talked into detail about that and the unique specifics to California and really the importance of it in looking at all of the cost of living within a unique geographic area and how that will influence the development of a public benefit program. The other thing that we looked at as part of our work is the existing administrative structures that could be utilized to help reduce new program development and implementation costs. And, again, just really looking to the need that there's no really requirement to re-engineer the wheel, that you can utilize a lot of existing administrative structures and benefit from reduced cost in actually building up a new program. The other is to identify structures that can be used to determine new program eligibility, and in this instance, looking to the the Healthy San Francisco program, there were already some eligibility structures in place that could be utilized for new program, and that's one of the areas that that entities really need to take into consideration is how will your eligibility process work in coordination with other APTC, advanced premium tax credit eligibility processes. And lastly, really looking at the identifying existing funding streams that can be used to finance subsidies provided to new program enrollees for possible sources of funds, new funds for program development. San Francisco was fortunate to have the existing structure of the Healthcare Security Ordinance and the city option programs that were created under the HCSO. They provided both an existing funding stream along with existing administrative structures that can be utilized to help reduce the program startup efforts and costs. With that, I'm going to turn over to the next slide to Anika Chowdhury from San Francisco Department of Public Health, and she's going to walk us through project outcomes.
Thank you, John. So using the report that UC Berkeley and HMA prepared for us, we had some key takeaways that were instrumental in helping us develop a proposal to address the affordability of health insurance in San Francisco. From the UC Berkeley report, the key takeaways were that San Franciscans are at risk for both uninsurance and underinsurance, and the factors that contribute to this are that, as Laurel mentioned, the cost of living is estimated to be about 59% higher than the national average in San Francisco. And secondly, current insurance trends toward increased cost sharing and higher deductibles leave people who do have insurance at the risk of being underinsured. And both of these factors contribute to increased vulnerability for people earning between 250 to 500% of poverty. And this is essentially because of the structure of the ACA subsidies, is that at incomes below 250, there's a very rich federal benefit available, and the subsidies decline between 250 to 400% and are not available between 400 to 500%. And at incomes above 500%, the increased income might be enough to mitigate the increased cost of insurance. From the HMA portion of the report, we learned that the key takeaway was that San Francisco's existing city option provides the strongest foundation for addressing our affordability concerns. And the benefits of using this structure would be that we have an existing infrastructure in place that we can leverage. This also leads to lower administrative costs because we already have a third-party administrator that we can use. And for the beneficiary, this might be nice because some of the beneficiaries who will be eligible for this new cost-sharing assistance benefit would be already familiar with the city option structure. And finally, the MRA benefit is such that it's flexible enough to administer both premium assistance and cost sharing. Next slide, please. So using those findings in the report, we developed a multi-part approach that we proposed to the Health Commission to address the affordability of healthcare. So the first here would be the creation of a new component under the city option called the Bridge to Coverage. And the Bridge to Coverage will offer premium assistance and cost-sharing assistance to eligible San Franciscans. And Bridge to Coverage seeks to increase enrollment in insurance and to reduce uninsurance. And I'll provide a little bit more detail about this on the next slide. The second part was to extend the Healthy San Francisco Affordability Extension. And the idea here is that this will allow San Franciscans who are not eligible for ACA coverage or those who are experiencing affordability challenges to remain in Healthy San Francisco. And this is in the interest of extending continuity of care, as well as ensuring that everyone has access to coordinated care. Finally, we also proposed a study to assess the feasibility of the Department of Public Health partnering with employers and businesses in the city to encourage employer investments in workplace wellness programs, with the idea that these partnerships would yield population health improvements in line with our citywide health improvement plan. And we plan to undertake that sometime in the next year. Next slide, please. So Bridge to Coverage, this is more detail on the benefit in the program. So individuals who are eligible for this benefit would be San Francisco residents who receive employer contributions to the city option. They must be eligible to purchase insurance on Covered California, not eligible for Medi-Cal, and the upper income threshold would be 500% of the poverty level. The benefit that they would be eligible for would be individually calculated for that person to increase the affordability of health insurance. So it would offer both cost sharing and premium assistance. The premium assistance benefit is calculated at 60% of the cost of insurance after applying all available federal subsidies. And so this mirrors the finding that San Francisco's cost of living is 59% higher than the national average. And the cost-sharing assistance is calculated to ensure that the insurance deductible for that silver plan is no more than 5% of the income. And so this is in line with the Commonwealth finding that people whose deductible is higher than 5% of their income are considered underinsured. The graph at the bottom here shows how this benefit might work for an example 40-year-old San Franciscan at various income levels. So the cost of health insurance varies by age and also by income, and the level of subsidies affect what the person's cost will be. So the 100% mark here is the full cost of the plan, which is roughly $7,000 for the year if the individual were to meet their full deductible and their out-of-pocket costs. So you can see at the lower level, at the lower income spectrum at 150% of poverty, nearly 82% of the individual's costs are covered by federal subsidies, shown in blue. Another 14% would be covered by the bridge to coverage benefit, leaving this individual to cover about 4% of their costs. Toward the higher end of the income spectrum, we see that people between 400% and 500% do not have the benefit of the federal subsidies. So the bridge to coverage benefit would cover about 41% of their full costs for the plan, and the consumer would be responsible for about 60% of the cost. So it's important to note here that the cost that the consumer would be responsible for would obviously depend on their utilization. Next slide, please. So currently we are in the process of implementation, and we feel that we've really, we're complementing the options available under the Affordable Care Act and seeking to ensure that that affordable health care is available to all low and middle income San Franciscans. The Health Commission approved the three-part proposal and the mayor endorsed our proposal. And so we're expecting to launch bridge to coverage in sometime next year, hopefully in the summer of 2016. And there are several expected benefits. The first is that we're hoping to increase affordability for about 3,000 residents in the first year. Secondly, the bridge to coverage benefit increases access to affordable health insurance for low-wage and part-time employees. These were concerns that were highlighted by employers and employees. And the benefit to the city is that we're able to leverage an existing funding stream. On the access side, Healthy San Francisco Affordability Extension, which will be effective January 2016, will continue to maintain our safety net for those who don't have other options. And this really helps mitigate charity care costs citywide, not only for the health department, but also for our other healthcare providers in the city. So we're very much looking forward to implementing this and making a real difference in affordability of health insurance for San Franciscans. Thank you.
Great. Well, thank you, Anika, and also Don, Donna, and Laurel. Those were terrific presentations. We now have plenty of time for questions and answers. I haven't received any yet, but we'll wait a minute to see if any come in. Please don't hesitate if you have any questions at all. While we're waiting, I will, I guess, pose a question to the group of both the sponsors at San Francisco Department of Public Health, Colleen and Anika, as well as the consultants. I wonder whether there are any surprises in conducting this analysis, either in terms of particular challenges that you encountered but didn't expect to, or findings that you learned through this endeavor that surprised you. And I think we need to, is everybody up? Lines open? Yeah. Any surprises?
Hey, Chris, it's Don Novo from Health Management Associates. I think, one of the things that was a little surprising on our end is as we conducted our analysis and had discussions with the qualified health plans, thinking about how you would be able to connect payment, the different payment options. So you would have an enrollee's personal share payment, and then potentially additional payment from the public benefit program, in addition to the advanced premium tax credit. So it was really kind of the difficulties of how you connect, 3 different payment sources together and the processes that the qualified health plans would have to deal with in kind of back office reconciliation and the difficulties with that.
Great, thanks, Don.
This is Laura Lucia from the Berkeley Labor Center. I guess one of the things that was challenging for us in doing the affordability analysis is that households' expenses can just vary so much, especially at this time when cost of living in San Francisco is changing so rapidly. It's difficult to systematically say who can afford health insurance and who cannot, and also people's medical use varies so much. So that's the reason that we did the 4 different affordability approaches. But I think going into it, I didn't realize, how difficult it would be to capture affordability in a systematic way.
And this is Colleen from San Francisco, and in support of what Don said around the complexity, not only the complexity in the program design, but now that we're in the implementation phase, it's quite complex to implement as well. Even though we have a strong structure of medical reimbursement accounts and eligibility functions through the Healthy San Francisco program, it's still quite a complex program to implement. So that too was something that we were surprised at.
Great. Well, thank you all for sharing those insights. Colleen and Nick, I wonder if, since you announced your decision, whether any other counties or others have reached out to you about this effort. Are you, we understand that San Francisco was unique in many ways, including the structure of the city option. Has anybody shown interest outside of San Francisco in this effort, to your knowledge?
Not to my knowledge. Certainly, when I talk about it in among other counties, there's interest, but no detailed questions about it so far.
Okay, thanks. And I will just reiterate, because I know many people joined a few minutes late and perhaps after I started my remarks, that part of our goal in this webinar is to share the work that was done in San Francisco broadly, but also to invite other counties, other stakeholders around California, if there is interest in pursuing an effort like this, some analyses along the lines of what Laurel and Donna described, we would be interested in hearing that. So one question that came in, I suppose this is for Colleen and Anika. This is the question of how would you approach building a similar system in a community that would be starting from scratch? I think recognizing that each community is very different, so it might be a difficult question to answer without knowing a lot more about the community and the underlying infrastructure in terms of both the population of uninsured, the working population, the financing available, the structure of the workforce and employers there. But having said all those caveats, if there are any sort of blanket insights or advice, I open it up to the panelists to share them.
So this is Colleen. I would say funding is certainly the key issue there. And when we first embarked on this project, certainly we had the funding available through the Healthcare Security Ordinance, but we were thinking about it in other ways also. So our county is a provider county. We have a full continuum of healthcare services that are operated under the Department of Public Health. We were thinking too about what it might mean to reduce the number of uninsured, to instead help subsidize people to get insurance, reducing charity care and uninsured costs on our own healthcare system. And maybe even at some point in the future, if our own healthcare system was one that was participating in a plan on the exchange, we might end up retaining the same patients who were at one time uninsured and now with choice in insurance continue to choose us under a covered California plan. So that was another way we were looking at financing this particular project. In terms of the benefit design, I feel like we've done a lot of work before this particular project ever started to create a medical reimbursement account benefit design. So we have looked at many different designs and found that that was one, a reimbursement account is one that was the easiest to manage and perhaps the easiest for participants to use because it looks like other kinds of reimbursement accounts you might get on the private market. So I would say that not recreating the wheel in that instance was also a helpful decision point for us.
Thank you. All right, any other questions for our panelists? Okay, well, if not, we will wrap up. We have contact information for everybody who spoke on today's webinar. I want to thank first our panelists for their time and efforts, and as several of them said, this was a more complex endeavor than anticipated at the outset, and we certainly appreciate all the hard work and perseverance to overcome those challenges. We congratulate San Francisco for its success, and just want to thank all those who joined today's webinar for doing so. Please don't hesitate to contact any of us if you have any follow-up questions. And with that, we'll adjourn today's webinar. Thank you.